So, welcome to Organic Tales, the podcast where we talk about organ failure, organ donation, and transplantation. Today, we're talking about kidney disease from stage 1 to kidney failure with two experts in the field. My name is Job Wako, a kidney transplant recipient, and I'll ask them to introduce themselves, starting with Dr. Soki.
My name is Soki. I'm a kidney specialist. I'm a doctor, and happy to be part of this.
Thank you.
Ronald? Thank you for having me. My name is Ronald Kasyoka. I'm a kidney health advocate and a personal development coach, and I'm also an author of a book. And thank you.
Wow, thank you so much for being here. Yeah, the book is here already.
Yeah.
And we'll put a link to his pages so that you can buy the book.
Okay, thank you.
So, Dr. Soki, set the stage for us. What is chronic kidney disease?
So I like explaining it from the idea of what the baseline is. So we are all born with 100% kidney function, and it's actually 100% kidney function with some reserve. So I like telling my patients, think about it like a full tank of fuel in the car and a reserve tank. Now we don't know how much is in the reserve tank. Men will always have more reserve than women, right? And if you're born premature, then you don't have enough time to form as much reserve. That's why you'll find your kidney doctor asking, were you born premature? It usually causes a lot of laughter, by the way, okay, in the consultation.
Yeah.
Yes. But what happens over time is that for all of us, so you have to think about the kidney, you think about the kidneys as two organs located right here in the back. As kidney doctors, we think about kidneys as 3 million organs because each kidney contains about 1.5 million filters on average. Can have more, can have less. So each filter is filtering on its own. So there comes a time as where we're using up our reserve as we go on with life because of illnesses or dehydration or medication or whatever it is that affects the filters. The number of these filters reduces over time. So for all of us, beyond the age of 40, most of us will start eating. We've finished our reserve and we're eating into now the main tank. And we start seeing kidney function reducing by about 1% per year. It's not that this was not happening before. It's just that we didn't know what was in the reserve. But in general, if you think at the age of 40, you start losing 1% and you had 100% because everybody's born with 100%, then that should take you to about 140 years. Sounds good and without a problem, right? Yeah. So,
Interesting.
yeah. So, in essence, what is kidney disease? It means that our percentage kidney function, in quotes, something that we call it, it's easy to call it a percentage kidney function, but it's actually the glomerular filtration rate. So the glomerulus is the filter. So glomerular filtration rate, and it's usually what is normal is maybe above 90, so 90 to 120.
Okay.
So we'll usually just say,
yes. It goes above 100.
It does, of course, because it's not actually a percentage. It's a glomerular filtration rate,
Okay.
the rate at which the glomerulus filters.
Okay.
So when it starts falling below, so it's just easy to say on average 100 and then call it a percentage. So it makes it, we'll usually say that as your kidney function falls, then we start saying, okay, we might have kidney disease. Depending on your age, anything above 60% or GFR of 60 might be normal, right? And but when it starts to fall below that, and especially the rate at which it is falling, we have to ask ourselves why it's falling, right? And we have to ask ourselves why it's falling at the rate that it's falling. So we start categorizing you as kidney disease, chronic kidney disease. But that's not kidney failure. So a lot of people have chronic kidney disease, 60%, 50, 40, 30, 20. That's not kidney failure.
Okay.
That's just CKD.
Yeah. And what is a nephron? So there's a nephron, then it's a glomerular. I've always known of a nephron.
So the nephron, we call it the functional unit of the kidney.
Okay.
And the nephron consists of the glomerulus and then the tubule. So I like likening it to a little funnel or a little sieve, and then the tubule coming out of it, and the tubule has maybe four parts or 5 parts, right? And each of those parts, so the tubule also has a function. So we don't usually talk about the tubule. So once the sieve has sieved, what the sieve does is the sieve just keeps in what the body wants, in essence. So the sieve will keep in protein, the sieve will keep in blood. Those two should never be sieved, right? So we should never find them in the urine, right? But what comes out now is water and everything else. And then each part of the tubule starts reabsorbing what the body wants back into the blood vessel. So that functional unit of the glomerulus plus the tubule is the nephron. Yeah, and then at the end of it, now all those tubules join together to form the pelvises and the renal calyces, and then your ureter, and that's your drain pipe. That's how your kidney works.
Oh, wow. Thank you for that in-depth explanation.
Oh yeah, was it too in-depth? I'm sorry.
I think you need to know. I think these are things
Yeah.
you need to know.
Yes, yes.
So I'll go to Ronald for a bit. How did you find out you have chronic kidney disease?
Okay, mine, I started feeling weak, drowsy, and also dull.
Yeah.
And I also started vomiting, and over time, I started feeling weak. At first, I thought maybe the feeling weak was because maybe I had not eaten, after that feeling, feeling dull or that. So at first, I tried to ignore the symptoms, but with time, they persisted, and I had to come to see the doctor now. After a few tests that were done, now the doctor said that I had kidney failure. But before that, I used to be treated for nephrotic syndrome from around 2012, which now progressed to kidney failure in 2019.
Yeah.
So it was a chronic illness now, which later caused the problem. And after that, the doctor advised that I be put on dialysis.
Yeah.
I was put on dialysis. I started dialysis. So dialysis it does the work which could have been done by the kidney. So dialysis acts like an artificial kidney. So you go for dialysis twice every week. Mine I go twice every week.
Yeah.
It's normally on Tuesdays and Fridays. Yeah.
Wow, you have a different experience from me. So for me, I didn't have that time knowing I had chronic kidney disease. I fell into dialysis. So I thought I was healthy, and the next day I was on dialysis. The doctors told me it's glomerulonephritis. And by the time I knew, kidney disease is silent, as we all know here, I'm sure. But I didn't know until I was in stage 5. And maybe Dr. Soki can now explain to us the stages and what the different stages are and what are the causes of kidney disease, the main causes after that.
So I think the two of you, and thank you for that question, are just an excellent example of how kidney disease does not choose as, with age. And many people will think, I can't have kidney disease because it's a disease of older people, or it's a disease because of diabetes or high blood pressure. Yeah. But you never knew you had high blood pressure. So the thing about kidney disease is, and now that we've talked about percentage kidney function, is you never needed 100%, right? And that's the problem. And what happens is that you have a disease process that is getting rid of the filters one by one. And you don't notice, or the kidney function is enough until the point at which kidney function starts falling below 20%. That means of all those nephrons that you had in your tank and in your reserve, what is left is 20%. You didn't notice because it doesn't have any pain, doesn't have any symptoms, because those 20% of sieves were enough. And for many people actually at your age, because of the reserve, all other organs are okay. Many times in glomerulonephritis, is most people don't come in until kidney function is actually below 10%. Right? So glomerulonephritis is one cause of kidney disease or kidney failure. And remember, the glomerulus was the sieve, and the nephron, and itis is inflammation, so inflammation of the nephron, right? That's glomerulonephritis. And there are many different types of glomerulonephritis. Some of them cause nephrotic syndrome.
Nephrotic syndrome, yes.
So both of you were within the spectrum of the same thing that was happening. Okay. But what it actually means is a disease of the sieve, where you'll start to notice that within the urine you had protein and you had blood, or one of the two or both of them. Okay. And as we talked about, the sieve should never let out blood or protein. Those two things are never waste. And in doing so, when we find protein and blood in urine, this is an indication that we have something wrong with the sieve, right? Yes. So this problem is called glomerulonephritis. Okay, and it means either the sieve is inflamed, or it means that something is harming the sieve, so that now where there should have been slits allowing only certain things to come out, the slits are being destroyed, so the sieve can no longer sieve. So what you'll allow out is water, but you're not sieving, right? So people just notice, I still have urine, how can I have kidney failure? And many people will be on dialysis and they still have urine, but that is glomerulonephritis for you. So that's one of the causes of kidney disease or kidney failure. Glomerulonephritis, if found early enough, can be treated, but many times there's no symptoms. By the time we come in, it might be too late. Of course, now these are diseases of the kidney. Glomerulonephritis is a disease of the kidney. There are some glomerulonephritis that affect other organs in the body.
Okay.
So if you're told you have glomerulonephritis, you can have minimal change disease. Probably you as a child had minimal change disease. That affects children.
Okay.
And then as you grow older, sometimes minimal change disease metamorphoses itself and becomes FSGS, focal segmental glomerulosclerosis. Yes. So this is another type of glomerulonephritis. It means it was never a minimal change disease. It was always FSGS. Then there's IgA nephropathy. IgA nephropathy is very rare in our population. It occurs away from the equator. We have membranous nephropathy. It tends to occur in older people. But all of these are inflammatory diseases of the kidney, right? Okay. Then you can have diseases of the body that now come and affect the kidneys. By the way, the most common of that is, of course, diabetes. Then we have people who have hypertension for a long period of time because of something else. We have many, many young women who get kidney failure as part of lupus spectrum or connective tissue diseases. And then we have people who, especially older people, who get kidney disease because now there was an obstruction to the drainage of the kidney. There was never a problem with the kidney, but the kidney, you remember the ureter was the drain out. If you block that drain, what happens? You just can't make urine anymore, and if that stays long enough, then it ends up damaging the kidney. So you can have a pre-renal problem, that's how we categorize it. What's happening in the body coming to affect the kidney. You have an intra-renal problem, the problem is in the kidney, or you can have a post-renal problem where you have obstruction. This happens in women many times who have like cancer of the cervix, where that blocks the kidney, or in men because of prostate issues, that blocks the kidney. So this tends to happen in older people as we go along. Yeah.
Oh, thank you for that, Dr. Soki. Maybe we'll go to Ronald. Yes. So what is your experience on dialysis?
My experience on dialysis. Okay, I've been on dialysis now for the last 5.5 years.
Okay.
I can say that it's been quite a challenging journey, but I've learned something that through all that time, though it has been that challenging, I decided to be strong for myself. If you reach a point that you are pitying yourself, you find that is what most of the times brings you down. But if you try and stay strong for yourself and just try to keep pushing, you find that you're able to find that strength also to keep you going. And for me, I decided to be strong for myself because I love my life and I want to live and enjoy every moment of my life. Just have beautiful memories. And I can say during all that time that I've been battling kidney failure, interacting with people, mostly children who are going through the same situation, I see most of them tend to lose hope when they felt sick. Most of them tend to lose hope because, when we hear about a chronic illness, most of people associated with, like, this is the end of life. I can't do anything beyond that. So most people just quit everything and just lose hope on life and whatever they were doing. So interacting with these children, most of the time I try to sit down, just talk with them, just share those stories of hope, just to encourage them and also motivate them. And in my book, Embracing Hope, there's a story I tell about this young boy. He's my friend. He's around 7 years.
Oh, wow.
Yes, I met him this day and I was sitting with him in the waiting area. We were waiting for treatment. And just sitting there talking to him, sharing just that moment and seeing him laugh, because I'm an artist also, so I decided to do some drawings for him. Children love art, things to do with cartoons, animation. So just having to draw for him and seeing him smile, just that was a way of just appreciating and making him somehow forget whatever he was experiencing and maybe going through. And I can say, though the journey has been challenging, it is those stories, those just sharing those stories, meeting people, talking to them, encouraging each other, that keep you going. And also, most importantly, try to stay strong. Be strong for yourself and be active. I like being active because that makes me to keep going. Because I notice something in myself. If I say that I'm going to stay indoors, that is when I feel much weaker. And also, I also see myself sick. I can do things, but whenever I'm out there, I'm stepping out there, I'm meeting people, I'm going out with my friends, events, just working with people, I'm able to find this strength and it makes me also forget all these things and makes me just to keep going, exploring new ideas, meeting people, and creating beautiful moments. So yes, that's what I would say.
Wow.
And also try to appreciate the people around you. There's this something that I learned recently on gratitude in pain. So you find that most of us who are going through these problems, most of us try to see it as this big challenge, and it seems to restrain them from even appreciating the small things like coming, visiting your doctor here. I think you should even come with a gift, say hello. Yes. Yes.
I get a lot of snacks.
Yes, say hello.
I get a lot of
Yes,
snacks.
and also say thank you. Just appreciate, and also your caregivers, support from friends. That's more having that more appreciating mind. The gratitude, it will also insert this energy in you and just keep you going. Yes, that's what I would say. Be grateful for whatever is around you, whatever is making you to keep pushing every day. Yes.
Wow, thank you so much, Ronald, for even the advice, the words of encouragement to anyone who's going through kidney failure out there. It's really encouraging, to see the work you've done.
Thank you.
Yeah, going through this condition. Yeah, you're welcome. For me, I know that, and maybe Dr. Soki can talk about this. Once you're diagnosed with chronic kidney disease, what happens next? You have to get an access. And what kind of access are those? For you, what access do you have right now?
Right now I'm using a catheter.
A catheter. Maybe you can talk a bit about that.
Yeah. Okay, so when I first, the doctor diagnosed that I had kidney failure and was put on dialysis, they did put a catheter, permanent catheter. And that is what has been since then, from 2019 up to now. Just the same catheter. I think I've been taking care of it.
Wow, yeah.
They have advised several times that I do have fistula.
Yes.
But okay, I'm not fearful, but I've had several surgeries on my leg.
Oh, okay.
So I thought maybe it would be better that I just keep the catheter. It's okay. I would not try to make anyone see the bad thing or whatever. But what I'm trying to say that I decided that since the catheter has worked well for me, I think maybe yes.
Yeah, because I had a catheter as well, and I moved to a fistula. And yeah, I saw the advantage of both. A fistula, they say, helps with clearance, and that's something that also you can talk about. You feel better when you have a fistula, but it's also the maintaining of the fistula. And if you don't like needles, the dialysis needles are big, guys. They're so big. But you get to a point where you get used to them, if I can say that. And what you're saying about appreciating, like, what are you living for, becomes very important. Because, this is something that you can take in your stride and you keep moving, and we'll eventually get to a transplant, which we can talk about later.
Yes.
But Dr. Soki, I wanted to ask you to explain. So someone arrives here, they're in stage 5, then failure, like kidney failure, and what next? How do you take them through to the point of dialysis and even a transplant? I can talk a bit more about transplant when you get there, but take us through the steps when a young person comes, then kidney failure, what next?
Ronald, so humbled
Thank you.
for the positive space that you're maintaining, and actually, I think you've just hit it straight on the head. But it's easier said. It's easier said than done, I think. And kudos to you for always focusing on gratitude.
Thank you.
And indeed, that's what we try and encourage our patients to do. It's difficult for anybody, but when somebody comes in, and many times people do walk in, and it's just creatinine 1,600.
Which is high, right?
That is extremely high. So a normal creatinine in a young person should be below 100. And by the time you start getting to about 500, that's definitely less than 10% function. Usually around 400 is less than 10% function. So when somebody walks in, as kidney doctors, we focus on where that person is, and we focus on, so a kidney does 6 things mainly, and we focus on 3 that can cause us a problem. So if your potassium is too high, and that is the work of the kidney in terms of salt balance, right? Then potassium is toxic to the heart, let's say that, yeah? So that is life-threatening. That is our first thing.
Okay.
The second thing is, how much urine is this person making? Because remember, everything that you drink must come out.
Yes.
So if you drink 1 liter, you should make urine of 1 liter.
Okay.
If you drink 2 liters, you should make urine of 2 liters. If you drink 10 liters, you should make urine of 10 liters, but don't drink 10 liters, please. I find people with humongous, I'm like, you will dilute your sodium, this is not good. Too much of anything is not good.
Yeah.
So the second function of the kidney that we're interested in is how much urine are you making? Even if the urine is not good quality urine, it's not removing waste, how much are you making? And you'll find people who come in, legs swollen, can't breathe, that is life-threatening, right? So that means dialysis immediately. Okay? And that's because our first priority is always patient safety, right? And the third thing we look at is how much urea, not creatinine, you have in your body, because urea is the problem. We use creatinine to give us an estimate of kidney function. You'll see the GFR is always eGFR. The E is about its estimated, right? It's not exact.
Yeah.
But urea is the one that usually gives us a problem. Urea is the one that makes you itch, makes you nauseous, gives you hyperacidity. And urea in its most extreme forms can cause the brain to swell. So you find patients coming in a little bit confused. And can also cause the heart to malfunction. So if we think that urea is getting to this point, another emergency, I will dialyze immediately. So it changes the conversation, right? And the fourth thing that kidneys usually do is acid balance. So salt balance, removal of water, removal of waste, and acid balance. The other 2 are hormonal functions. So with acid balance, usually we can do something about it. We give bicarbonate and we're usually fine. So that's rarely a problem. But many times people come in because they've been stable for a long period of time, and then something triggered them to sort of become unstable, an infection or something like that.
Yeah.
That is if I have hyperkalemia, high potassium, if I have fluid overload, or if I have very high urea levels, this is an indication for me to start dialysis immediately for the patient's safety.
Okay.
But if we're not there, let's have a conversation. I find that many times people start dialysis as an emergency and it's very traumatic for them. If we don't have any one of these, let's have a conversation about starting with the vascular access. And we try and buy some time using medications. So what is the vascular access? The vascular access is a fistula. We like fistulas because a fistula does not have any plastic. A fistula is your own blood vessels. And a fistula means that it is far away from the heart. It's less likely to get infected. And once it grows, it can give us really good dialysis because the fistula will always be fatter than the catheter. Okay, thus it allows better flows, right? So with a fistula, you can go up to blood flows of 500. With a catheter, a good blood flow with a tunnel catheter, big catheter, is maybe about 350, 400 if you're pushing it. Okay. And this allows us better clearance on dialysis. So the efficacy of your dialysis is always related to how much blood we're able to pass through that machine. So we like fistulas. We like fistulas. why we don't like catheters is because we usually put in a catheter into the internal jugular here, and a catheter now just sits at the entrance of your heart. So if we get an infection into the catheter, that infection is going into your heart, and people can get a bad infection called infective endocarditis, which is an infection of the heart that can cause the heart now to become a problem. So this is the reason. But if we come in an emergency, the catheter is life-saving. We will use the catheter, And many people do very well with their catheters. But we, as kidney doctors, we're always pushing for a fistula. Sometimes you can't get a fistula because you don't have good veins. Small veins, damaged veins, fine, we can't get it. We will work with the catheter.
Okay.
And many people have had many catheters for a long time. So person comes into the clinic, we do this assessment for them, we try and explain to them the things that we have talked about, where we stand, and then we make a plan going forward. It's not just jump, we're going to admit you, no, let's make a plan going forward. Let's try and understand, and then we're going to do this and we're going to do that. Inevitably, many times it does end up in dialysis. More and more, especially with new medications coming out, it doesn't have to be. Many times we have a clinic called low clearance clinic where we have people with percentage kidney function somewhere between 15 and 25, and we can stay there for years depending on where we are. But every person is an individual, and you have to look at them in that way. Sometimes people don't have good social support, and sometimes people live very far away from the hospital. Sometimes people are unable to adhere to medications and all of the stuff that comes with hanging out with your doctor. And these are not good candidates for low clearance clinic. For them, leaving them without dialysis access and dialysis can put their lives in danger. So always patient safety first. So you assess, doctors are very judgmental. We're judging you from the moment we walk in, but you're not allowed to judge us.
Steps.
You're not allowed to. Yeah, but it's so you take your patient in as a whole person and sort of make a judgment call on the basis of that. Yeah.
Okay. And so, let's go to you, Ronald. So I know you're a motivational speaker.
Yes.
And you've written a book.
Yes.
Maybe you can tell us more about some of your work before we start wrapping up.
Okay. Okay, so my name is, as I said, is Ronald Kasyoka, and I've written a book, Embracing Hope. Here is my book, actually, Embracing Hope. So I'm sharing my story, battling kidney failure for the last 5 years, to encourage and inspire other patients and also people going through difficult challenges, to show them that it does matter what you're going through, that you can still live your life, do your things. You just have to believe in God and keep pushing forward. And what I would say is that try as much to push yourself. So don't just sit there and pity yourself. I would say try to be an inspirational story yourself, because you find that most of the times when you have chronic kidney disease, we understand that it's a big challenge for everyone, but having that, the resilience just keep going, that is what matters. And I would urge each one of us to just be inspiration themselves, just strive as much to encourage everyone who is around you. Yeah.
Oh, thank you so much, Ronald.
Thank you.
And as we wrap up, we'll talk a bit about a transplant, a kidney transplant. Doctors push for patients or people living with chronic kidney disease on dialysis to get a transplant. Why?
Well, let's try and put it very directly, I think, and very simply. So we talked about the filters, and we know the filters are filtering 24 hours a day, 7 days a week. And that means that at any time when we check your blood, we should not find waste. We should find the acid looking very nice. We should find salts within their levels. But what happens when we are on dialysis is that we dialyze on Tuesday.
Yes, Tuesdays and
on
Fridays.
Tuesdays and Fridays.
Yes,
We
2 times
dialyze
a
on
week.
Tuesday. You come in with creatinine of 1,000. We run you through the machine, just scrub you out, and you feel it after.
Yes.
And then we come out of there with creatinine of 200. And that's a massive drop. Or we went in with a urea of 30, we come out with a urea of 8 or 10, depending on what we did. And that's just a massive drop. So the body is usually in equilibrium, and then we cause this disequilibrium, right? We remove all of these things suddenly, including water, and then maybe 4 liters or 5 liters, something like that. And then what we do over the next few days is reaccumulate. 1 liter per day, urea increasing from 10 to 12 to 15 to 16 to wherever it goes, and then we come and do that all over again. This is not normal. Yeah. Right? So the accumulation of fluid and then the drastic removal has its implications on the heart, which is caused to stretch and then to rebound. And while we are accumulating that fluid, you tend to find some people who are very fluid sensitive and their blood pressure goes up and then suddenly crashes down. These fluctuations are not good. And then also the effect of having low blood vessels on the vasculature, on your blood vessels, on your brain, on your heart, because one of the functions of the kidney that we didn't mention, we mentioned there were 2 hormonal functions, isn't it, of the kidney. Number 1 is to make blood, and number 2 is to make your bones. So over time, if we're not careful, and when we're on dialysis, we do not even encourage the blood levels to be normal because we have to artificially increase them using medications. So while normally a man should have a blood pressure of maybe 14 to 16, in dialysis we have a blood, if we're lucky, a blood level of about 10 to 12 or 11.5. We don't like it going above 12. If it falls below, and all of those times, for example, if you have a blood level of 10 and then we're on dialysis, we remove blood for 4 hours. It's outside the body, so that means during dialysis, hemoglobin level is lower. Yeah. In time, it starves the heart, it starves the brain of oxygen. So all of these things over time take their toll. Let's not get it wrong. Dialysis is life-saving. Yeah. And let's not get it wrong again. Dialysis has come a long way. From 20 years ago, 30 years ago, it's not the same thing that we are doing right now. And in actuality, a lot of the issues that we see in Kenya with dialysis is because we're doing dialysis 2 times a week. How many times a week did you dialyze?
3.
3 times a week, right? So that means whatever I eat today is removed tomorrow. So it doesn't have time for fluid accumulation or a lot of waste accumulation and everything. And it allows us quite a normal diet. Yeah. You don't have the severe restrictions of 2 times a week dialysis. So, but what happens over time is that dialysis takes its toll because of this. So where possible, if it is possible, if we have a donor, we do encourage everybody who can get a transplant to get a transplant, because the new kidney will come in and do all of those things. It comes with 1.5 million filters, fresh, and it tries to heal your bones. And the damage that is done during dialysis, we might not be able to completely heal that, but we can heal a lot of things and at least try and reset where we were before. So that's why we encourage a transplant. Transplant is not for everybody. You do have to have a conversation with your doctor about whether transplant is for you. Some people don't qualify, some people are unable to get a transplant. But where we can, it is a good option. And it also, of course, gives you the freedom of diet, of travel. So we do encourage people to have a transplant. Yeah.
Thank you.
Do you agree?
I agree. As a transplanted person, I agree. Yes.
Yeah, sure.
And that's a conversation I'm sure we can get into in another episode.
Yeah.
So I'm going to wrap up real quick. Yeah. For those living with chronic kidney disease, whether in the earlier stages or in dialysis, transplant, there's a kidney clinic here in Nairobi Hospital. And I'd like Dr. Soki to quickly tell us what hours people can pop in, and then we'll have Ronald wrap up as well, and then we'll end the session.
So thank you for that. Of course, we have our offices here at Nairobi Hospital. We're in a group practice with myself and Dr. Kakai and Dr. Marie Kubo. So on most days, and we also have a combined diabetes and nephrology clinic with Dr. Odhiambo. So we actually sit down with our diabetic patients and make our decisions together and give the patient a conclusion in one sitting, and that's just for the convenience of the patient rather than running between 2 doctors. So we have our clinics on Mondays and Wednesdays and Fridays, and then we have a special clinic on Saturdays for students who can't come during the week, and we have donor clinic on Tuesdays, and that's for our transplant workups. So usually our day off, which is transplant day during the week, is either Wednesdays or Thursdays or Saturdays when we do our transplants here at Nairobi Hospital. If you could put the link maybe for our clinic, we're happy see you and to be part of the kidney journey, as it were.
Thank you so much, Dr. Soki.
Can I give a take home?
Yes.
That many times people don't want to go and check on their kidney function because they are afraid of what they'll find. But if kidney function is found deteriorating early, many times we can preserve the filters and don't end up in kidney failure. So the earlier kidney disease is detected, the better. Yeah.
Thank you so much, Dr. Soki. And for all the help with patients,
not at all. It is inspiring actually to listen to all of the stories, and it gives the human face to the science that we deal with. And I think it really helps in terms of managing your patient to understand. Yeah.
Thank you. Ronald, a parting shot.
I would love to say that, to tell everyone who is going through this situation that there is still hope, and to just keep fighting, keep pushing, and just know that if you stay strong for yourself, at the end of it, you will come out victorious. I believe that. And I would also want to thank our doctors for the good work that they do, taking care of the patients, and also our nursing specialty. They're doing the dialysis so that,
Amazing.
And also for the children who are going through this, I want them to know that they still hope and they have more life to live. So just keep pushing, follow their dreams. I will say that you will achieve them if you believe you can. And for recently, I started a foundation under my name, Ronald Kasyoka Foundation, where we are running a campaign to support children on dialysis. So we are doing counseling services to them and also to their caregivers, where we just sit down, talk, and share those stories just to encourage and inspire them. And we're also offering medical support from the books and also partnering with people. Yes.
Wow, well done. That's really good work. And thank you for coming in.
And thank you. I appreciate it for having me.
Awesome. So, as we close, I'd like to say we're having our next physical kidney transplant support group in August. Please follow our socials for more details. And until next time, take care.